Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left
hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today we're putting on our scrubs and stepping into what I think is probably one of the most intimidating units in pediatric nursing.
Oh, absolutely.
We are tackling the endocrine system.
It is a beast. It's completely invisible. It's all chemical. And let's be honest, it scares a lot of nursing students. But it's also, I like to call it the ultimate Goldilocks system.
Goldilocks. Like not too hot, not too cold.
Exactly. Everything has to be just right. I mean, if you have too much hormone, you're in a crisis. Too little, a totally different crisis.
Yeah.
And when we're talking about children, these aren't just, metabolic inconveniences. They literally alter the entire trajectory of a child's growth and development.
That sets the stage perfectly. And just to orient you, the listener, we are treating this deep dive like a high-yield coaching session today. We're acting as your nursing educators.
Wow.
We've pulled a really specific, massive chapter on pediatric endocrine disorders. So we're covering the pituitary, thyroid, adrenal glands, and the parathyroid.
And our mission here isn't to just read the textbook to you. That'd be painfully boring. We're going to cross-reference this material to extract the Pareto 80-20.
The 20% of the concepts that answer 80% of your exam question.
Exactly. And more importantly, the stuff that prevents catastrophic errors at the bedside.
Right. So fewer lists, more logic. Just a quick disclaimer before we jump in, though. This is an analysis of the provided text for educational purposes. We are here to help you learn, but, always follow your specific hospital protocols.
Shall we dive into the map?
Let's do it. So before we get into the specific diseases, you notice three really distinct patterns of pathology in the source material. These are the big buckets that exam writers just love. What's the first pattern?
So the first pattern is what I call the growth velocity seesaw. In pediatrics, growth is basically a vital sign, right?
Yeah.
So you have diseases that just slam the brakes on growth, like growth hormone deficiency or hypothyroidism. And then on the exact opposite side of that seesaw, you have diseases that hit the accelerator way too hard.
Like precocious puberty or hyperthyroidism.
Precisely. So for the exam, your priority is recognizing those deviations on the girl chart.
It's often the only red flag you get at first, right?
It really is.
Yeah.
If a child falls off their percentile curve, or if they are, crossing percentiles upwards way too rapidly, that is your stop sign. You have to investigate.
Okay, got it. Pattern two.
Pattern two is the salt and water extremes. This is honestly where students get mixed up the most.
Oh, yeah. Electrolytes are tough.
They are. So on one hand, you have diabetes insipidus, which is a dry, high sodium state. And you contrast that directly with congenital adrenal hyperplasia, or CAH, which almost always presents as a dehydrated, low sodium, high potassium state.
I love that distinction. One keeps the salt, one loses the salt. And we're going to unpack that mechanism in a lot of detail in a bit. What is the third pattern?
The sudden crash emergencies. Endocrine disorders can be really slow burns, until they suddenly are. We're talking about thyroid storm, adrenal crisis, and the seizures or laryngospasm you get from hypocalcemia.
The terrifying stuff.
Right. These are the absolute can't-miss signs where a patient can just collapse right in front of you.
Okay, let's unpack this properly. We're going to go disease by disease, applying that 80-20 rule. Let's start with the pituitary gland and growth hormone deficiency, so hypopituitarism.
Right. The one-liner here is really simple. The tank is empty. The pituitary fails to secrete somatropin.
So these kids are usually born at a normal weight, right? But then as they age, the fuel just isn't there to maintain the pace.
Exactly. Looking at the pathology, it's an impaired metabolism of proteins, fats, and carbs. It could be a genetic defect, could be a tumor, or even trauma.
But what does it actually look like when they walk into the clinic?
Well, the age-specific presentation is the key here. At birth, they usually look completely normal. But later, you start seeing those falling percentiles we talked about.
Right.
The need-to-know findings are short stature, decreased muscle mass, and delayed puberty. But here's the major nuance for exams. Their proportions are normal.
So they aren't disproportionate, they just look like a much younger version of themselves.
Exactly. They look like a perfectly proportioned younger child.
And the intervention is pretty straightforward. We just replace the hormone.
Yes, subcutaneous growth hormone therapy, usually somatropin. It's a daily injection. But here's the critical complication the text highlights, and exam writers absolutely love testing this one. You need to watch for painful hip or knee joints.
Wait, hip pain? That seems totally random. Why hips?
It's just physics, really. You are chemically forcing the bones to grow rapidly with the medication. If that growth happens too fast, the structural integrity of the hip joint can actually fail.
Oh, wow.
Yeah, the femoral head literally slips off the neck of the bone. It's called slipped capital femoral epiphyseal, or SCFE.
That sounds incredibly painful.
It is. So if you have a parent calling the clinic saying, he's doing great on the shots, but he's limping, or his knee hurts.
You don't just brush that off as growing pains.
Never. That is not growing pains. That is a medical emergency. You stop the drug immediately and get an orthopedic consult.
That is a massive safety tip. And developmentally, I imagine being much shorter than all your peers takes a huge toll.
A huge impact. Self-esteem and body image are major nursing concerns here. You're treating the physical height, but you also have to aggressively support the child psychologically.
Because they probably get babied a lot.
All the time. By teachers, by peers, just because of their physical size, even though their cognitive development is perfectly age-appropriate.
Okay, let's flip the seesaw then. Let's talk about when the biological clock runs way too fast. Precocious puberty.
This is clinically defined as puberty starting before age 9 in boys or age 8 in girls.
Which seems incredibly young to me.
It is very young. And here is the paradox that constantly trips people up on exams. These kids have a massive growth spurt early on. So at age 7, they might be the tallest kid in their class by far.
So parents might be thinking, great, he's going to be an NBA player.
Exactly.
Yeah.
But it's a trap because those early sex hormones trigger the growth plates in the bones to close or fuse way too early.
Oh, I see.
So they shoot up fast, fuse the bones, and then they stop growing completely at age 10 or 11.
So the really tall 7-year-old becomes a very short adult.
Precisely. If left untreated, they will have significant short stature as adults. The need-to-know findings here are premature pubic hair, breast development, and that advanced skeletal maturation you see on an X-ray.
And what's the treatment? How do you stop it?
You basically have to hit the pause button. If there's a tumor causing it, you remove it. If it's central precocious puberty, you use a GnRH agonist, something like leuprolide.
And that just tells the pituitary to calm down.
Exactly. It tells the pituitary to stop shouting at the ovaries or the tests.
Developmentally, this feels incredibly tricky. You have a 7-year-old girl who physically might look 14.
That is the primary nursing challenge, honestly, outside of administering the meds. Her cognitive development is age-appropriate. She's playing with dolls. She thinks like a second grader.
Yeah.
But the outside world treats her like a teenager.
Right.
The risk of inappropriate social expectations and even sexualization is very real. We really have to coach the parents on that social mirror effect.
That's a really powerful perspective. Okay, let's move to pattern 2, the salt and water games. This is usually the hardest section for nursing students to grasp. Let's start with the high and dry disorder, diabetes insipidus, or DI.
Central DI. This is a lack of ADH antidiuretic hormone. I always tell my students to just call it the anti-peeing hormone.
Because if you don't have the anti-peeing hormone,
You pee a lot.
massive amounts.
Massive. The kidneys simply cannot concentrate the urine.
Yep.
So the core findings are polyuria, which is lots of urine, and polydipsia, and insatiable thirst. In a toilet-trained child, seeing them suddenly start wetting the bed, that anuresis is a classic warning sign.
And the labs, because this is crucial for the exam.
High serum sodium. Think high and dry. They are losing pure water, so the blood left behind becomes really salty. You get hypernatremia.
And the urine.
Because all that water is just dumping into the toilet, the urine is extremely dilute. It has a very low specific gravity, usually less than 1.005. It practically looks like tap water.
Now, safety-wise, the text mentions a medical alert bracelet being mandatory.
Absolutely mandatory. Think about it. If this child is in a car accident and is unconscious, they can't ask for water. But their body keeps dumping fluid anyway.
They'll just dry out.
They will dehydrate and seize from hypernatremia incredibly fast. The bracelet speaks for them when they can't.
And for nursing care, we are obviously watching intake and output like a hawk. Now let's pivot to the adrenal glands. We talked about high and dry DI. Now we need to talk about congenital adrenal hyperplasia, or CAH. This one always trips me up.
It's complicated. But think of it as a broken factory assembly line. The adrenal gland is trying to make two critical end products, cortisol and aldosterone. But the factory is missing a worker, a specific enzyme, usually 21-hydroxylase.
So the factory can't make the final product.
Right. But the brain doesn't know the factory is broken. It just senses low cortisol and screams, "Make more cortisol," by sending tons of ACTH.
So the gland works over time?
Yes, it gets huge, that's the hyperplasia, but it still can't make the cortisol.
So where do all those hormone building blocks go?
They get diverted down the only assembly line that's still open, which produces androgens, male sex hormones.
So if you have a genetic female infant with this...
She's born with ambiguous genitalia, an enlarged clitoris that might actually look like a penis. That is often your first assessment clue in the newborn nursery.
But the real need-to-know crisis isn't the genitalia, it's the salt, right?
Correct. Remember, they also can't make aldosterone. Aldosterone is your body's salt keeper. Without it, the kidneys just dump sodium into the urine.
So these babies have hyponatremia, low sodium.
Yes, and because sodium and potassium constantly trade places in the kidneys, they also develop hyperkalemia, high potassium.
And they go into shock.
They do. This is the adrenal crisis.
Mm.
Dehydrated, low salt, high potassium, and tanking blood pressure. It is the exact physiological opposite of the DI patient we just talked about.
And the treatment is lifelong replacement. You just have to give them what they're missing. Glucocorticoids like hydrocortisone and mineralocorticoids like fludrocortisone.
That's right. And there is a massive parent education point here that exam writers test constantly. It's called stress dosing.
Tell me about that.
This is the #1 safety teaching point for CAH. Cortisol is our natural stress hormone. If a healthy person gets sick or breaks a leg or has surgery, our body naturally pumps out extra cortisol to keep our blood pressure up and manage the stress.
But that these kids cannot do that.
Exactly. So if they get something as simple as the flu,
The parents must increase the dose.
they have to, sometimes double or triple it depending on the protocol. If they don't, the child's body cannot handle the physical stress, they will go into vascular collapse, and they can die.
That is a stark reality for a parent to manage. Just knowing, my kid has a fever, I need to up the meds immediately or else.
It saves lives. It's
Yeah.
completely non-negotiable.
Okay, let's pivot to the thyroid. We have two sides of the coin here, congenital hypothyroidism and hyperthyroidism. Let's start with congenital hypo.
This is a classic catch-it-early diagnosis. It is arguably the most critical endocrine screening we do in a newborn. The baby is born without enough thyroid hormone.
What does that baby look like? The text describes a, quote, quiet baby.
Right, and that sounds really nice to a tired new parent. Oh, he's such a good baby. He sleeps all the time. He barely cries. But it's actually a huge danger sign. Lethargy, poor sucking, cool, dry skin.
And there's a structural clue too, right?
Yes, a very specific finding is a persistent open posterior fontanelle and an enlarged protruding tongue.
And why is it so critical to catch this early?
Brain development. This is the ultimate 80-20 takeaway. Thyroid hormone is literally fuel for the developing brain. If you miss this and you don't start sodium levothyroxine immediately, it results in permanent intellectual disability.
That is heavy. So the development impact is essentially saving their cognitive function.
100%.
Yeah.
That's why we do the mandatory neonatal heel prick screen in all 50 states. We're specifically looking for low T4 and a high TSH.
Now, flip the coin. Hyperthyroidism, Graves' disease. The engine is running way too hot.
This one usually hits in adolescence. Everything speeds up. Hyperactivity, weight loss, even though they're eating like a horse, heat intolerance. You'll see that classic exophthalmos, the bulging eyes, and really velvety smooth skin.
And the sudden crash we look out for here is the thyroid storm.
This is an absolute life threat. It's an abrupt, massive release of thyroid hormone, often triggered by stress or an infection. The patient becomes incredibly restless. They get a high fever, severe tachycardia, diaphoresis.
It's like the body is vibrating apart.
It really is. You have to intervene immediately with beta blockers and antithyroid meds to slow the heart and block the hormone.
Now, often they will treat this by removing the thyroid surgically, but the text warns about a very specific post-op complication. If you take out the thyroid, what else might you accidentally grab?
The parathyroid glands, they sit right on top of the thyroid, and they're tiny. If a surgeon accidentally nicks them or removes them, the body's calcium regulation just disappears.
Which leads us perfectly into topic 7 on our outline, hypoparathyroidism.
Right. It's usually an accidental surgical complication. No parathyroid hormone means sudden hypocalcemia.
And low calcium makes the nervous system, what, really twitchy?
Extremely irritable. You get tetany. The classic nursing assessment here is the Chvostek sign. You tap the facial nerve right on the cheek, and the whole side of the face twitches.
But the killer, the one that stops your breathing, is laryngospasm.
Yes. The airway muscles literally cramp shut. So if you are caring for a kid post-thyroidectomy, you need a tracheostomy tray and IV calcium gluconate right at the bedside. You are watching that airway like a hawk.
Okay, we've covered the disease processes. Now let's move into the medication module. We've touched on a few of these, but let's drill down on the specific nursing pearls from the text. First up, growth hormone, or somatropin.
So, administered subcutaneously. The PEDI pearl here is your monitoring. We already hammered home the hip and knee pain for the slipped epiphysis.
Right, no growing pains.
Exactly.
Ah.
But you also need to watch for rapid weight gain and increased thirst, because growth hormone can actually mess with glucose metabolism and cause insulin resistance.
Good to know. Med 2 is levothyroxine for the thyroid.
I call this the picky eater of medications. It has to be given on an empty stomach.
Mm-hmm.
The text explicitly says to avoid giving it near food consumption because things like soy formula or calcium supplements completely block its absorption.
And in an infant who eats every 3 hours, that is really tough timing.
It's incredibly frustrating for parents, but you have to find that window. Because if the dose isn't absorbed, the brain doesn't develop.
And you monitor the pulse with this one.
Yes. If the resting heart rate goes too high, it usually means the levothyroxine dose is too high. You're pushing them into hyperthyroidism.
Med 3, desmopressin or DDAVP for diabetes insipidus.
This comes as an intranasal spray, oral pill, or SQ injection. It works great. It stops the massive peeing. But here is the major safety alert: water intoxication.
Break that mechanism down for us.
Think about the patient's routine. The child's been uncontrollably thirsty for weeks, drinking gallons of water every day. You give the med, and the kidneys suddenly stop making urine.
Okay.
But out of sheer habit or psychological drive, the child keeps drinking those gallons of water.
But now the water has nowhere to go.
Exactly. It stays in the blood, it severely dilutes the sodium, you get rapid hyponatremia, the brain starts to swell, and they seize.
So you have to strict limit their fluids.
You have to restrict fluids the moment that medication starts working. You can't let them drink like they used to.
That is a critical balancing act. All right, Med 4, corticosteroids like hydrocortisone.
We covered the big one here: stress dosing. Never ever skip a dose. And similar to growth hormone, long-term use of steroids can actually stunt growth velocity, so we monitor their height closely.
Finally, calcium gluconate. This is for that emergency hypocalcemia we talked about.
The safety alert here is all about the IV line itself. Calcium is terrible for the veins. It's highly caustic.
So if it leaks?
If the IV infiltrates, meaning it goes into the surrounding tissue instead of the vein, it causes extravasation, you get tissue necrosis and sleeping.
The skin will literally die and peel off.
Yes, it's a severe chemical burn, so you absolutely must check that IV site patency and get a good blood return before you push calcium, every single time.
Let's move to our cross-linking and synthesis section. We've been connecting dots as we go, but let's solidify a few key things. First, let's look at the developmental delays. We have the slow growers versus the fast growers.
Right. GH deficiency and hypothyroidism are your slow growers. Precocious puberty and CAH are the fast growers. But here is the real kicker for pediatric nursing. All of them require hormonal manipulation to normalize their trajectory.
So it's not just about the numbers.
Not at all. The goal of nursing care isn't just fixing the lab values. It is getting that child back onto the standard growth curve so they can hit those milestones, both physical and social, at the appropriate time.
And then there's the fluid safety aspect. I want to reiterate this because it feels like the biggest trap for an exam, or a real shift.
It is the one that kills if you get it backwards. You have to know your patient's underlying disease.
So if it's diabetes insipidus,
They are dehydrated and hypernatremic. They have too much salt, they need free water fluids, and DDAVP.
but if it's an adrenal crisis from CAH,
They are also dehydrated, but they are hyponatremic. They have no salt. So they need salt restoration, isotonic fluid resuscitation, and steroids.
if you treat them the same just because they both look dehydrated,
You will hurt them. You have to look at the sodium levels.
that right there is the deep dive difference, understanding the why behind the dehydration.
Exactly.
All right, we have covered a massive amount of ground today. Let's wrap this up. If you are listening to this on your way to a big exam or your next clinical shift, what are the big 3 safety takeaways to keep in your pocket?
Number 1, stress dosing for CAH. Parents must know to increase the steroid dose during any illness to prevent shock.
Got it.
Number 2, medical alert bracelets for diabetes insipidus. It speaks for the child when they physically can't ask for water.
And number 3.
Hip pain reporting for growth hormone therapy. Do not ignore a limping child on somatropin. Rule out that slipped epiphysis immediately.
Perfect. And as we sign off, I want to leave you with a final thought to kind of mull over. We spent a lot of time talking about labs and hormones and IVs, but think about the social impact here.
Right. I mean, imagine being that 7-year-old girl with precocious puberty. She is trying to navigate a grade school playground in a body that looks 14. She is dealing with social pressures from older kids and adults that she just isn't cognitively ready for.
Or the 10-year-old boy with growth hormone deficiency who looks 6, constantly being patted on the head and treated like a toddler by his teachers.
It's exhausting for them.
The nursing role isn't just adjusting the hormone dose. It's protecting their childhood. It's advocating for them so that their physical appearance doesn't dictate their social worth or how they're treated in the hospital.
Very well said. These patients aren't just lab values. They are children on a disrupted growth curve, and we are the ones helping them find their balance.
Thanks for diving in with us today. Good luck on the exam and, stay curious.
See you next time.